So at that point, the ER actually, the total exam was fine, physical exam was fine, so no CAT scan was needed. But they said, he's got underlying psych issues, let's call psych. So they actually got a psych consult on this guy because he was having visual hallucinations at the school. So psych cleared him as a baby, adjustment disorder, whatever it was, and sent him home. But the dad had him that day, and he said, you know, something's wrong with my kid. I don't know what it is, but something's wrong with it. It's just not making sense. He would tell him to do something, and he'd say yes, and then not do it, where he would be able to do it before. Or he was talking to something that was not there. So the dad said something, he's just not behaving right. So the dad took him to another general hospital. They did a CAT scan. CAT scan, of course, was negative, and they said, oh, you're fine, go home, okay? So by my visit, this is the fourth person, and what no one ever asked him was, do you feel dizzy? Are you blurred vision? And it turns out what the visual hallucinations they were seeing was that he was actually seeing double. And he would see past a person, and when the school was there were a lot of people behind him. He was actually seeing people coming back and forth. So by the time he spoke to somebody, they were already gone, but he had seen them. So the school thought he was having visual hallucinations where he was actually seeing double. And I'll go through that exam. But once I mentioned and go through the physical exam, once I mentioned that, you know, he's got pictures, he was so thankful. It's like, thank you. Because he came in demanding, I want a blood test. I want a blood test for my child. Something's wrong with my child. I want a blood test. I don't know what it is, but I want a blood test. And so once you do your history and your physical exam, you explain to him, oh, this is a concussion. He's like, oh my God, thank you, because someone gave him the diagnosis and validated his symptoms. And he didn't get a blood test. So your exam. So what I hope you, yeah. Okay, so the one thing, sorry for all the stories. So the one thing I want you to learn is how to do a proper concussion evaluation. And it's all about eye movements and the ocular motor exam. So the eyes are the windows to the brain. And why test eye movements in concussion? More than 50% of the brain's pathways involve vision and visual processing. And if you think about what your brain does, 70% of the sensory information that you get from anywhere comes through your eyes. And your eyes have to process that information. Like you're wearing a white shirt, you're sitting all the way in the back. All that information comes through your brain. Your brain has to process it, store it somewhere so that you can pull it back later if necessary and process that. So if there's any issue anywhere in the brain from any injury, the first thing that's going to be affected is your vision. It identifies dysfunction, non-exerting cognitive testing. And there's this article out of Brain where impaired eye movements and post-concussion syndrome indicate suboptimal brain function beyond the influence of depression or intellectual ability, so you can't fake it. Common findings that we see include abnormalities in saccades, smooth pursuit, vergence, accommodation, the vestibular ocular reflex, and photosensitivity. Anybody here know what those are? Anybody heard of any of that? Okay, so this is where I hope to actually impart some knowledge on you, because this is all you need to do is learn how to assess these, and you're golden. So, and what these, so just the simple act of saccades, and what saccades is, and this is the study that we did with sideline testing that involves saccades. It's the ability, and this is what you do reading, it's the ability to move your eye from one word to the next really quickly. Your eye actually doesn't move smoothly. It jumps from common, has to think about that word, see it, and then go to the next one, findings. And it actually does that in very fast time, so it's just moving your eyes from one word to the next. And there's a way to assess that. But just that movement of saccades involves a wide network of anatomical structures in the brain. So that sensory input, and efferent input, is going from the cornea nucleus to the dorsolateral prefrontal cortex. It's going through the frontal eye fields, going through the parietal eye fields, or supplemental eye fields, coming back down to the visual cortex, back to the eyes, and back up. That's just saccades. When you think about convergence, it's got a whole nother complex pathway of visual processing to go through. And then vergence, and that's the ability to move your eyes in, and vestibular fields. All of that involves the brain. So if you have a head injury, a lot of times kids bump their head and just feel some pain in the head. So, and that can be, they can have a headache just from that point tenderness. But if they have any visual issues, and they're not going to complain about it, you have to test for that, that's affecting your brain. That's already brain involvement. and that's how you can distinguish the difference between, is it the brain or is it just the skull, okay? And so these are the physical exam, specific physical exam deficits in concussion. And what we'll do is, if you guys want to partner up with someone, I'm going to have you do these on each other, because you're not going to be able to understand. And I actually do have a video, so should we do the video? Right there. Try the video in the part. Wait, do you want to? Okay. Well, let's go to the next one. Oops, sorry. If it works. If the video doesn't work, then oops. Oh, do we have? Oh. All right. So if you forget any of this, I don't know why. Yeah.
Hi, I'm Dr. Christina Master. I'm one of the sports medicine physicians and one of the co-directors of the Minds and Concussion program here at the Children's Hospital of Philadelphia. We see a lot of concussions in children here at the Children's Hospital, and we're sure that you do as well. We'd like to share with you a lot of the new information that we're learning and update you on how to best diagnose and identify concussions in children in your practice.
You know, I'm going to skip some of this because I know we're short on time, but this is the piece.
Help you identify concussions in your practice. All right, Ava, so tell me about your last concussion.
It happened about a month ago.
Okay, tell me a little bit about how it happened.
I was going to a corner with a kid who was bigger than me, and he hit me from behind.
Okay, and did you have symptoms right away?
No.
When did you start to have symptoms and start to wonder that maybe you had a concussion?
The next day.
Okay, what were those symptoms?
I was feeling nauseous, I had a headache.
You guys want to do this in the back?
Okay, and you were able to finish the game without any problems?
Yes.
Okay. Did you go to school the next day?
Yes.
Okay. What happened at school?
I couldn't focus, my head hurt.
When did you start to think that you had a concussion?
That night.
Okay. And then at that point, did you seek care with anybody else?
My mom.
Okay. All right. And that's when you decided to call and get an appointment to come in. And were you continuing to do homework?
Yes.
And how about spending time on your cell phone or a desktop computer?
Yes.
And how did those make you feel?
They made my head hurt.
Okay. Have you done any exercise since you had your injury?
No.
Okay. And then after resting for a bit at home, did that help your symptoms a little?
Yes.
Okay. In addition to the history of the current concussion, we'd also like to get some past information on her. We usually like to find out how she's done in school prior. Her history.
I kind of want to get to
Ask if there's any history nearsighted or farsighted after concussion, and a sign of motion sickness in the car may.
So she's talking, okay.
You should take a look at my finger. Follow my finger with your eyes. Don't move your head. We'll start slowly and go faster. Let me know if it gives you any symptoms. Otherwise, if it doesn't give you any symptoms, we'll keep going, okay?
So this is smooth pursuits that
As you
she's
see,
doing.
Ava's doing a great job following my finger. And as we go faster, she's able to keep up. She doesn't have any problems with any symptoms. She's not blinking or having her eyes water excessively or complaining of headache or dizziness. Just to note, when you track, sometimes you can have a few beats of nystagmus at the end, gaze, like she has here, that's normal. But when you come to the middle, she locks in nice and solid, there's no nystagmus in the central gaze. This is the smooth pursuit portion of the exam. Now, Ava, I want you to hold your head still. I want you to look at my fingers, left, right, as fast as you can.
You can do this on the
until it gives you
sidewalk.
symptoms, or I tell you to stop, okay? Go ahead. Now, as you can see, Ava is performing the horizontal saccades. She's going nice and smoothly. It's not fatiguing, it's not tired. She's not blinking or stopping because she's having a headache or dizziness. Oftentimes, when kids are acutely symptomatic, they will have trouble with this movement. What happens is they'll often have their eyes start to water, or they'll blink, or they'll stop, and they'll say that they have either headache or dizziness provoked by this maneuver. Let's do it up and down now, Ava. Up and down, keep your head still, look at both of my fingers as fast as you can.
This is vertical saccades. Now kids get very
So again, as you can
dizzy
see,
and uncomfortable.
Ava's not having any
with down
symptoms.
concussion.
She's not having any
So
water
now
in
she's
her
not having
eyes, her
problems.
eyes are not
Normal
fatiguing.
exam.
She's
You guys
not
can
blinking or
practice on
stopping
each other,
because she
and
has
you'll notice
dizziness
that
or
you're
headache.
able- and
But
you're
often
able to
what
do
we'll
it
is
without
ask
moving your
the
head.
kids, did that cause any dizziness or headache, Ava?
Gestures.
Great, wonderful.
Moving your eyes.
Take a look at my thumb. I want you to focus on my thumb, and then I want you to bounce And keep bouncing and let me know when that starts to give you any headache or dizziness or bother you at all. Otherwise, we'll keep going and I'll tell you when to stop. This is the vertebral vestibulo-ocular reflex for stability testing. All right, you can stop, Ava. That looks great.
So this is where kids
have
have
symptoms
issues
with
with
this,
this.
so often
Imagine in
stop,
school,
or they'll be
looking out the
quite
window,
rapidly.
from side to side.
Often they can have
That's your
their eyes start to water or some kind of worsening headache or dizziness. Now we do the horizontal vestibulo-ocular reflex. Focus on my finger, shake your head side to side, and keep going until I tell you to stop or if it gives you symptoms. Great. Did that give you any symptoms at all? Headache or dizziness? Great. So now we're going to measure some binocular visual function. In particular, we're interested in convergence, and this ruler is called a convergence rule. You can purchase this. It's a specialty piece of equipment used by developmental optometrists. If you don't have access to a convergence rule, you can also use a pen and have the patient bring it close to their face and their nose to estimate what their convergence is in the same manner. We're going to have her take a look at the letters on this card. We're going to ask her when they become blurry and when the line becomes double, and that'll give us a sense of where her convergence point is.
I'm just going to skip this for a second. She's got this convergence rule. You don't have to do this in the ER. Obviously, no one's going to have that. What you can do, it's the ability for your eyes to converge inwards and focus on a point. So what you can do, and you should be able to converge within 6 centimeters of your nose. So if you have one finger on the kid's nose, so I know, and you can always measure your own fingers, basically that 6 centimeters is the length of my pointer finger. So what I usually do is I have a pen light that actually has a B on it, or you can even like Energizer, like this battery, like has an E. You just have them focus on a letter. It doesn't matter how, it should be a big letter, and you bring that object close to their nose. And you to ask them, it's going to get blurred first because a lot of that's focusing, that's a combination, but tell me when it becomes double. And you can do this to yourself. You can see at what point your vision becomes double. That E or that whatever that item is becomes double. And that should fall within 6 centimeters from your nose. Kids with concussion, they break or it becomes double back here, like 10 centimeters, 8 centimeters, 9 centimeters, 12, even 20 centimeters. Sometimes it's back here. That's a problem, that's a concussion. Also, it should not make you dizzy, nauseous, should not make your eyes hurt, you should not be watering. You should be able to do that without symptom provocation. So that is the convergence insufficiency piece of it. And that's what you can do in the ER.
Ava, take a look at the letters.
We'll skip some of this.
Oh.
She's doing accommodation too, which, and basically the accommodation, if you cover one eye, you're kind of doing the same thing, bringing in that finger closer to you, and at what point does it become blurry? And you can do it with each eye. It should be within 10, and this is age dependent, so that's why I'm not even going to tell you I'm going to tell you don't even bother with that, because it depends on the age. So for like an older person, it's going to be like 15 centimeters, whereas a younger person is going to be 20 centimeters. So don't worry about that piece of it. And then she's just doing balance. And it's, Romberg is useless, okay? And if you want to know the specificity and sensitivity of all of the tests that you actually do, this is where this article comes into play, because they go through that, like which descriptions or not, and this is useful. The other ones that you're typically used to doing, like the neurological exam and the upper motor neuron check reflexes, Romberg, that's useless. So it's a directed physical exam, okay? So this is really all you should be doing.
Eyes open, going forward, and then I'll tell you to close your eyes. Go ahead. Great, so you can see she's doing a great job. Now close your eyes. She has no sway, she's keeping her hands by her side. Open your eyes and stop.
And most kids with
now
concussion can do this, but they get dizzy. They get
It's
dizzy,
a little
they
more
get
difficult than going
lightheaded.
forwards.
They may feel
And
like
closing your eyes is the most
and
difficult
that's
part
not
of all.
for me.
Great, you can stop. So a lot of our kids, when they have an acute concussion, will have trouble with any of these maneuvers. Sometimes they'll sway back and forth. Sometimes they'll have their arms go up from their side to help them maintain their balance. And sometimes
Okay, so let me
what age group have they been validated?
So that's a great question, actually, and there was a study that recently came out. We're talking basically 8 years old and up, 8 or 9 years old and up.
Okay.
That probably just came out about validating the vestibular-ocular evaluation, and that's why this is a great article, because it talks about how everybody else in the country is, I should say, there's certain centers that are doing it and are validating this. So one thing about dysmetria, because that'll give you your cerebral, because you do want to test on cerebral. Again, it's only your finger. So one thing about dysmetria, you may see some of this, but keep in mind, it may be because they have visual defects or dysfunction, and they're seeing double. Because I had one kid like swipe my hand, but the way he was doing it was he was swiping across, because he would see 2 fingers. So, and that's a visual. So he had no problem with cerebellar, but because if he tried to do that, he couldn't figure out which finger to point to, but he would swipe across. So just keep in mind when you're doing that. So a way to determine the difference is if you have to do the fingers with thumb to each finger. Go ahead.
This might sound like a silly question, but what is the value of diagnosis concussion? Is there any evidence that any intervention you do prevents the post-concussion syndrome?
Yeah, so that's what we're going to talk about is the rest. It's really the rest is what you're going to tell them, because there is studies that show that, and this is the whole problem, what's sensible rest and what's not appropriate, is that if you send that patient out, number one, and you don't tell them, okay, you have a concussion, see you later, follow up with your doctor, but if you tell them they're not supposed to play in sports, they're going to get hit again, and they're going to have prolonged recovery and worsening symptoms that come back to your ER. So that's one thing you're going to tell them. And we'll talk about too. And another thing though is in terms of, wait, I just lost it. Sorry. Rest. Oh yes, thank you. Rest. There is a study that shows that if you don't do anything in terms of rest, and it's really visual rest and cognitive rest, if you just tell them, okay, go and do your daily activities, they take longer to recover. And that's been studied too. So you're going to delay recovery. They're going to come right back into your emergency room if you don't give them the appropriate instructions, and they're going to get the full workup, and they're going to have, they'll be out of work. So there's a lot of like potential problems, complications that they can have if they aren't directed in the appropriate room. Does that answer your question?
Yes, two more questions.
Uh-huh.
Is there anything on your initial physical exam or your findings that can predict who is going to have post-concussion syndrome or prolonged recovery?
Not on the physical, well, I say yes and no. So from clinical experience, and I think the data is probably still coming out, because if you look, I get all the news, all the concussion new research articles like every week. There is so much information that's coming out, like on a weekly basis. So this may be being studied right now as we speak. But there, in terms of physical exam, like there are some, like what I told you, the predictors, not on physical exam, but migraine history, ocular disorders, LD, learning disabilities, all those kids, those are all predictors of protracted recovery. But one of the other things too is significant visual disturbances, like convergence insufficiency, for example. Like if it's 20 centimeters and that kid cannot see, I'm going to send him sooner for a follow-up with someone who knows what they're doing as opposed to the general pediatrician who's not going to know anything. So, because that is a kid that's probably going to need some sort of vision rehab later on down the line. So this is from experience, because what I do is not only do I diagnose the kids in the beginning, but I follow them through recovery, and they get better for the most part. They do. But this is out of, like, usually they'll have maybe at 10 centimeters, 7 or 6, 7, or out. But if they have 20, those are the kids that I'm probably going to be referring earlier rather than later. So yes, there is in terms of just matters, there is another study that they just came out in terms of visual diagnoses and concussions. So 16, and they looked at their kids, and at the time that they were first seen, what percentage of their concussions have visual diagnosis, meaning issues with accommodations, CODs, all this convergence, and almost 70% of the kids with concussion had these underlying diagnoses. So those are the ones that you're going to follow, and you're going to make sure they recover, because if they recover, they're more likely to get injured the next time they do go out to play, because they're not able to turn their head and watch that ball coming. They don't have that head-eye coordination. So you're gonna do more damage if you don't recognize it by sending them out to play. So you should, as ER doctors, never clear a kid to return to play from the ER. Never. That is not something you wanna get involved with. Because once you identify these issues, because so many, and just so that you know, in the general population, these issues only come up in about 5% of the population. So there'll be some few of you that are gonna have issues with this, but only 5%. But in kids with concussion, almost 69, 70% of kids will have this. So now, if you have these, you're gonna have to prove that those ocular issues are not due to concussion. And then that puts you in a whole different, then you have that whole return to play issue and that whole return to play. They're gonna have issues in school. And with the conversions kids, these kids have a tough time reading. They cannot remember, they can't bring their eyes together to read that page. So they're going to have difficulties in school reading and not be able to stay in school for a full day. And so that's a kid that you're going to say, stay home for a couple of days, maybe start half a day, when you go back in, and I'll go through that in a minute. And then it may take another 2 weeks, a week or two, before they're in school full day. So those are kids that, ideally pediatricians can deal with this, but we're not in a perfect world, and certainly not in this in an inner city population. I don't know that any pediatricians will know what to do, or many pediatricians will know what to do. But that's true. So I think you guys being more educated at this point in terms of this right now will do a better job educating your parents about where to go and what to do after kids.